Welcome everyone. In this video we shall be talking about muscle relaxants, and in this part we shall be talking about the depolarizing muscle relaxants. Right, the non-depolarizing ones we shall be discussing them in the next video. Right, we all know that under depolarizing muscle relaxant we have only one drug, which is succinylcholine, also known as succinylcholine. Okay. Moving on to the first question. Succinylcholine produces neuromuscular blockade by. So we need to know the mechanism of action. So succinylcholine, we all know, is a depolarizing muscle relaxant, and its structure is very similar to that of acetylcholine. Okay. So if we talk about the mechanism of action, this succinylcholine binds to the acetylcholine receptor. It binds to the acetylcholine receptor, and it renders the receptor open. Right, and it renders the receptor open, which results in ion transport. Across the receptor. Okay. So this results in sustained depolarization. It results in a sustained depolarization. Why? Because the succinylcholine is not degraded by the acetylcholinesterase, which is present in the neuromuscular cleft. Right, the acetylcholinesterase, which is present in the neuromuscular cleft, cannot degrade the succinylcholine, and the succinylcholine keeps those channels depolarized. Okay. As a result, the repolarization phase is absent, right, and depolarization is continued, which results in no further action potential generation, and this would result in the muscle relaxation. Okay. Now if we look into the options, competitive inhibition of nicotinic receptors, no, this is the mechanism of action for NDMRs, non-depolarizing ones. Okay. Persistent depolarization of the motor entered, yes, this is our answer. Inhibition of acetylcholinesterase, no, this is the mechanism of action for the reversal agents. Like neostigmine. Okay. And blocking sodium channels, no, it does not block, it rather opens them. Okay. The answer should be option B. Moving on to the next question. Which statements regarding succinylcholine are true? It is structurally similar to that of acetylcholine. Yes, this is a true statement. We know this. It causes initial muscle fasciculation. Now, this is also a true statement. Why is it so? Because see, initially there is depolarization. This is the initial depolarization, where it opens the ion channels and keep them open, blocking the further action potentials. So this initial depolarization is responsible for the muscle fasciculations associated with the depolarizing muscle relaxants. Okay. It is metabolized by acetylcholinesterase at NM junction. No, that's a false statement. It is rather depolarized by pseudocholinesterase. The pseudocholinesterase or butyrylcholinesterase, which is produced by the liver, right, from the liver to the circulation, and finally from circulation it diffuses into the neuromuscular cleft, degrading the succinylcholine. Whereas acetylcholinesterase can degrade only acetylcholine in the cleft. Okay. It has rapid onset and ultra short duration. Yes, this is also true statement. It has a very rapid onset. The onset of action is within 30 to 60 seconds. Whereas and is also ultra short acting within 5 to 10 minutes. Within 5 to 10 minutes, its action is completed. Okay. So the answer should be A, B, and D. Option B should be your answer. Okay. Moving on to the next question. Identify the following train of 4 response. Right. This is the most important question of this topic. Right. So we have 3 things over here. Right. First things first. Right. Over here we can very well appreciate that fade is present in C, whereas fade is absent in both A as well as B. Okay. Next important thing that we look into the image is the height or the amplitude of the response. We have a high amplitude, we have low amplitude. Low amplitude means some amount of muscle blockade is present. So in B, muscle blockade is present. In C, muscle blockade is present, whereas in A, muscle blockade is absent. Okay. So now how do we classify? When both muscle blockade and fade is absent, that is a normal thing. Okay. Nothing has been administered, no muscle relaxants have been administered. When the muscle blockade is present but there is no fade, then that is phase 1. Of our DMRs. Okay. And when we have both muscle relaxation, both muscle blockade and fade, then that is phase 2. Of DMRs, or which is similar to that of NDMRs. ठीक है. The phase 2 of depolarizing muscle relaxants is similar to that of the normal response to non-depolarizing muscle relaxant. ठीक है. So with this information, we all know that our answer should be option A. That is, A is normal finding, B is phase 1, C is phase 2. But let's have a look into the details of phase 1 and phase 2, because this is the most important thing that we need to know. Remaining everything in this chapter are much more or less factual. Okay. So the phases of DMR, right? You all know that DMRs have two phases, phase 1 and phase 2. I'm sorry. Now phase 1 is our I'm sorry. Extremely sorry for the cut. Let's discuss this the two phases, right? We have phase 1 and phase 2 blocks in DMR. Phase 1 is the depolarizing block. Okay. What happens in depolarizing block? The succinylcholine comes and acts on the acetylcholine receptor, and they keep them open. They keep them depolarized. Now, when we provide the train of 4 response, we are providing 4 response in train of 4. With the first stimulus, maximum amount of acetylcholine will be released. Maximum amount of acetylcholine is released into the cleft, and it wants to act on the receptors, but the receptors are already depolarized, so we do not get any action. Now the second stimulus goes, a bit less of acetylcholine is released into the cleft. Again, that amount is trying to act, but they cannot because the receptors are already depolarized. Similarly, in the third and fourth, further less and least amount in the fourth one. Okay. So it does not matter, right? Acetylcholine concentration, amount of acetylcholine that is released into the cleft does not matter for a phase 1 block, right? We will have same amount of muscle blockade, whether you provide acetylcholine, whether you provide increased amount of acetylcholine to the receptors or not. Okay, that's why we have equal response in all the 4 stimulus. Okay, so this results in presence of this is the reason for no fade in phase 1. Whereas in phase 2, what happens? Phase 2 is seen due to high doses. When high doses of succinylcholine is administered, right? This is the non-depolarizing. This is the non-depolarizing blockade. What happens in non-depolarizing phase 2 blockade? There is desensitization of the receptors. There is desensitization of the acetylcholine receptors, right? Similar action as that of non-depolarizing muscle relaxants, right? Now, due to this desensitization of the receptors, they are not depolarized anymore, right? If you provide acetylcholine in this state, right, they will respond to the acetylcholine. Now we are providing those 4 stimulus. In the first stimulus, maximum amount of acetylcholine is released, as a result of which we would have the maximum response. Okay? Some amount of muscle blockade will be present, but we would have the maximum response. Next, the second stimulus comes, right? A bit less of acetylcholine is released. Now this would result in a lesser amplitude in the second stimulus. Then in the third stimulus, further lower amounts of acetylcholine will be released. We would get lesser response. And in the final stimulus, in the fourth stimulus, we would have the least amount, and similarly the response will also be least, right? That's why the fade is present in phase 2 block. Okay. This fade phenomenon will be present in phase 2 block, right? This is the main difference between phase 1 and phase 2. In phase 1, the receptors are depolarized. No amount, right? The amount of acetylcholine does not matter. Whereas in phase 2 block, due to desensitization, right, the receptors are not depolarized anymore, and they would respond to the acetylcholine. That's why the amount of acetylcholine matters over there, right? That's why the response depends on the amount of acetylcholine that has been presented to the receptors. This is the basic difference between phase 1 and phase 2, and this is the most important thing that we need to understand in this topic. Right? Remaining almost everything is factual. Now, similarly, since fade means fade, similarly, if we talk about post-tetanic facilitation, this also says that in post-tetanic facilitation, increased amount of acetylcholine will be presented to the receptors. In phase 1 block, will it matter? No, it does not. So post-tetanic facilitation would be absent. But over here, post-tetanic facilitation would be present, right? Because increased amount of acetylcholine would result in an increased response in phase 2 block. And another important thing, neostigmine. Neostigmine has no role in reversal. Why? Because neostigmine is just going to increase the amount of acetylcholine in our neuromuscular cleft. So in phase 1 block, again, that doesn't matter, right? Whereas in phase 2 block, neostigmine might have some role, right? At least theoretically, neostigmine has some role because it increases acetylcholine level. But again, practically the response to neostigmine is very unpredictable. That's why it is not used. Okay. So this is all about phase 1 and phase 2, which we should know. Okay. Moving on to the next question. Which are true regarding phase 2 block? Resembles non-depolarizing block, that's a true statement. Shows strain of 4 fade, yes, that's also a true statement. Occurs after repeated or prolonged infusion, that's a true statement, right? Usually with a dose more than 5 milligrams per kg. Okay. The normal dose is 1 to 1.5 milligrams per kg. That if the dose is very high and is more than 5 milligram per kg, that can trigger a phase 2 block. And reversed reliably by neostigmine, this exact term reliably makes the statement false, right? Because of this unpredictable response. Right? Theoretically, neostigmine should have reversed a phase 2 block, but practically we get very unpredictable response. That's why we do not use them. So the answer over here should be A, B and C. Option C should be our correct answer. Okay. Moving on to the next question. The most common indication for succinyl choline in anesthesia in practice. Without doubt, it is rapid sequence intubation. Okay? This is our most common indication. Certain important things to know that if succinyl choline is contraindicated for any reason, especially head injury, if it is contraindicated, then we would use rocuronium, which is a non-depolarizing muscle relaxant. Okay. Another important thing regarding rocuronium is it is used for something called precurization, right? What is precurization? You all know that succinyl choline is a depolarizing muscle relaxant, right? It is associated with an initial muscle fasciculation. Okay. But if we provide small doses of rocuronium before administration of succinyl choline, we can avoid this side effect. So this is known as precurization. So this would avoid this muscle fasciculation and also post procedure myalgia. Okay. So the answer over here should be option C, rapid sequence intubation. Without doubt, it is the most common indication for succinyl choline. Okay. Moving on to the next question. Again, extremely sorry for the cut, right? A 28-year-old man undergoes emergency laparotomy under general anesthesia. Now, rapid sequence intubation is performed using succinyl choline for muscle relaxation. The surgery is uneventful, but at the end of the procedure, the patient fails to resume spontaneous respiration, remains apneic for 45 minutes, requiring continued mechanical ventilation. Which of the following is the most likely cause for this prolonged apnea? Now remember that prolonged apnea due to succinyl choline use can be due to only 3 causes. Number 1, we have provided very high amount of dose which has resulted in a phase 2 block. Okay, more than 5 milligram per kg dose has been given and it has resulted in a phase 2 block. Then something called the pseudocholinesterase deficiency, right? Pseudocholinesterase is the enzyme which degrades succinyl choline. If that is deficient, then again we would have the patient might land up with prolonged apnea. And the third is presence of atypical pseudocholinesterase. Again, the efficiency of pseudocholinesterase will be low, resulting in prolonged apnea in such patients. So our answer over here should be option C, that is pseudocholinesterase deficiency. If we look into the other options, myasthenia gravis is actually resistant to succinyl choline. Right? Because in myasthenia gravis, right, the patient is already on neostigmine. Right? Moreover, there are antibodies against those acetylcholine receptors, right, which can change the structure, right, which already block those receptors. That's why in myasthenia gravis, succinyl choline won't have any much of an effect. Malignant hyperthermia is a completely different thing. It does not present with prolonged apnea. Hyperkalemia, again we might get hyperkalemia with succinyl choline, but it would present with arrhythmias or cardiac arrests, something like that, not prolonged apnea. So our answer over here should be pseudocholinesterase deficiency. Now, what are the conditions where we can get the pseudocholinesterase deficiency? Right, in advanced CLD, chronic liver disease, we all know that pseudocholinesterase is produced from the liver. So in advanced CLD, we might get pseudocholinesterase deficiency. Second, in pregnancy, in old age, in OCP users, and in organophosphate poisoning. In these conditions, we can get pseudocholinesterase deficiency. And the third thing, that is atypical pseudocholinesterase. Then atypical pseudocholinesterase can be diagnosed using something called the Dibukane number. Right, based on the number, if the value is less than equal to 20, if the number varies from 0 to 100, right? If the value is less than equal to 20, this is homozygous. This is homozygous atypical variant, right? Homozygous atypical variant is present, right, where we would get this presentation of prolonged apnea, right, especially in these conditions. The next is when the value is 20 to 80, it is heterozygous. It is heterozygous atypical variant is present, right? These patients rarely land up with those prolonged apnea. And when it is more than 80, that is homozygous normal. Homozygous normal variant, right? Okay. So this category of patients are gonna land up with prolonged apnea. Okay. So moving on to the next question. A patient with known homozygosity for atypical cholinesterase or pseudocholinesterase failed to resume, right? He failed to resume spontaneous respiration after surgery. Which of the following is the best management for this condition? This condition is nothing but succinyl choline apnea. It is nothing but succinyl choline apnea due to atypical pseudocholinesterase. Atypical pseudocholinesterase. Okay. If we look into the options, administer neostigmine. Now the thing is that atypical pseudocholinesterase would result in decreased elimination or decreased degradation of succinyl choline. Right, the patient will still be in phase 1 block only. Right, there is prolonged phase 1 block due to atypical pseudocholinesterase. The patient does not progress to phase 2 block. That's why neostigmine would have no role, because neostigmine has no role in phase 1 block. Right. Continue mechanical ventilation. Yes, this is the best thing that we can do for the patient. Administer dantrolene sodium. No, dantrolene sodium has role only in malignant hyperthermia. Malignant hyperthermia, no role over here. Continue mechanical ventilation and administer FFP. That is the best thing that we can do, because this FFP can increase pseudocholinesterase production. Okay. So the best answer over here would be option D, although FFP is practically not administered. But if we get an option where both of them are present, mechanical ventilation plus FFP, that should be our answer. Had option D been not there, then option B would have been our answer. Okay. Moving on to the next question. The cardiovascular effects of succinyl choline include. The cardiovascular effects of succinyl choline, bradycardia, yes. Bradycardia is present. This is due to the initial muscarinic. This is due to the initial muscarinic stimulation. We would get bradycardia. Now this is specially seen. With repeated doses. Or in pediatric patients, or in patients who have pre-medications with opioids. Okay. Now in order to prevent this, we can pre-medicate. The patient with atropine, right, which would block the muscarinic receptors, right. Tachycardia, yes, this tachycardia follows bradycardia. Because the bradycardia was only transient. Okay, right. So this is due to the sympathetic stimulation. Sympathetic stimulation. Okay. Arrhythmias, yes, arrhythmia can also be seen, because these arrhythmias is due to hyperkalemia, because succinyl choline leads to potassium efflux. Succinyl choline results in potassium efflux, which can result in hyperkalemia, which can trigger arrhythmias. And hypotension, yes, we can also get hypotension, right. Along with bradycardia, we might get hypotension, right. But remember that this bradycardia and hypotension are very initial or transient response. The more common response is the subsequent tachycardia and also hypertension due to sympathetic stimulation. Okay. So our answer over here should be option D. All of them can be seen. Moving on to the next question. Excuse me. Succinyl choline causes increase in all kinds of pressure. Intraocular pressure, yes, it does increase intraocular pressure due to extraocular muscle contraction, and also due to this choroid vascular dilatation, right, that would cause increase in intraocular pressure. That's why it is contraindicated in glaucoma. Right, intracranial pressure, yes, it does increase intracranial pressure. This is due to increase in the cerebral blood flow. Right, that's why it is contraindicated in head injury. Contraindicated in head injury, we have read that in RSI, right? In rapid sequence intubation and head injury, we won't use succinylcholine, we would use rocuronium, right? Intragastric pressure, yes, it does increase intragastric pressure. This is due to the abdominal muscle fasciculation. This is due to abdominal muscle fasciculation, and this increases the risk of regurgitation. This increases the risk of regurgitation. Okay. Cerebral perfusion pressure, right? Cerebral perfusion pressure, we all know that cerebral perfusion pressure is equal to mean arterial pressure minus intracranial tension. We all know that the intracranial tension is increasing and the mean arterial pressure is normal, as a result of which the CPP should decrease, not increase. Okay. Cerebral perfusion pressure will decrease with succinylcholine. So answer over here should be option A, B and C. Okay. Moving on to the next question. Which of the following are contraindications for administration of succinylcholine? Burns, yes. Burns is because contraindication because it increases the risk of hyperkalemia. Because burns itself results in hyperkalemia because of degradation of the muscle cells, right? Because of degradation of the myocytes. Moreover, if we administer succinylcholine, efflux of potassium is just going to add to it and can trigger hyperkalemia and arrhythmias. Okay. Head injury we discussed because of increase in ICT. Duchenne's muscular dystrophy, this is also the indication. Any muscle dystrophy, any muscle disease will be contraindicated in succinylcholine, contraindications for the use of succinylcholine. Sepsis is also a contraindication. So our answer over here should be option D. Besides these, what are the other contraindications? Right. Remember that history of malignant hyperthermia. History of malignant hyperthermia is a contraindication because succinylcholine is a trigger for it. Right. Then we have glaucoma because of increased intraocular pressure. Even stroke leading to paraplegia. Right. But in very acute stroke, we might use succinylcholine. Right. Then advanced CLD, right, because liver produces succinylcholinesterase or butyrylcholinesterase. Right. And even in prolonged immobilization. Okay, these are the contraindications for the use of succinylcholine. Moving on to the next question. A 21-year-old man excuse me, is posted for open reduction and internal fixation of femur fracture under general anesthesia. Now, induction is done with the help of propofol followed by administration of succinylcholine to facilitate endotracheal intubation. Within minutes, the anesthesiologist notices the rapidly rising end-tidal CO2, masseter spasm, progressing to generalized muscle rigidity, tachycardia, metabolic acidosis, and a rapidly increasing core body temperature. What is the most probable diagnosis? Everything regarding malignant hypothermia has been given over here. Everything has been given. Right, it starts with masseter spasm. Masseter spasm is actually the earliest clinical feature. There was succinylcholine, which is a trigger for malignant hypothermia. Rapidly rising end-tidal CO2. Now this is due to increased oxygen utilization. Right, muscle rigidity tachycardia. This increased metabolism results in metabolic acidosis and increase in core body temperature. Okay. Without doubt, the answer is malignant hypothermia. Right, if we talk about the other options, right, neural malignant syndrome is usually seen secondary to use of antipsychotics. Nothing has been mentioned over here. Anaphylactic reaction would result in hypotension, bronchospasm. Such features have not been mentioned over here. There's acute thyrotoxic crisis. We would get increase in core body temperature. We would get tachycardia. But this muscle rigidity and this decrease in end-tidal, and this increase in end-tidal CO2 would be absent over here. Okay. So the answer over here is malignant hypothermia. Okay. Now with this we come to the end of our discussion on depolarizing muscle relaxants. In the next video we shall be talking about the non-depolarizing ones. And another important thing, like from 20th January my residency is gonna start, so I'll try to upload the videos, but the frequency is gonna decrease, right? Let's see what happens in my medicine journey, right? I'll try to upload videos as frequently as possible. Just as a note, like I made you all know that the frequency might decrease further. So if you all like this video, consider subscribing to my channel, and thank you for watching.